Hello dear student of the 5th stage of College of Medicine in Jabir bin Hayyan Medical University. Welcome to the 4th lecture in the topics of gastroenterology, and it will be about cystic fibrosis and lactose intolerance. You remember from the last lecture we talked about the malabsorption and take one example of it, which is celiac disease. If you remember, we talk about the causes of malabsorption according to the mechanism, and we mention 6 causes. It could be due to digestive failure, it could be due to enzyme deficiencies, it could be due to structural defect, or it could be due to mucosal abnormalities, and it could be due to infective agents, and finally due to systemic diseases affecting the GIT tract. In the last lecture, we take an example of the malabsorption, which is celiac disease, that is cover the example of the mucosal abnormality and systemic disease. In this lecture we will cover 2 additional examples, and very important, which is cystic fibrosis as an example of digestive failure, and the lactose intolerance as an example of enzyme deficiencies. In the first part of this lecture we will talk about cystic fibrosis, and we will leave lactose intolerance to the second part. Here we go. Now we will review the outlines of the first part of our lecture. We will take a definition of the cystic fibrosis, and we will know its pathogenesis, and we will know the clinical manifestations of the disease, and we will know how to approach for the diagnosis and what is the treatment of this disease. Firstly, we have to put a definition for cystic fibrosis. So how we can diagnose cystic fibrosis? It can be defined as it is an autosomal recessive disease, results in a syndrome of chronic sinopulmonary infections, malabsorptions, and nutritional abnormalities. So 3 elements in the diagnosis or in definition of the cystic fibrosis: chronic sinopulmonary infections, malabsorption, and nutritional abnormalities. And it is, as mentioned, an autosomal recessive disease, so it is hereditary disorder. Cystic fibrosis, for that, it's regarded as multisystemic disease affecting the lungs, the digestive system, sweaty glands, and the reproductive tract. So what about the epidemiology of the cystic fibrosis, which is very important to know why it is an important example of the malabsorption, and it is due to the digestive failure. It is one of the most common lethal genetic diseases in the United States. So its incidence is about 1 in 3,000 among Caucasian and 1 in 9,000 in Hispanic population, so it's more common in the white races. And it accounts for more than 70,000 worldwide, while in American it affects about 30,000 people, and they are living with cystic fibrosis. So more than 75% of people with cystic fibrosis are diagnosed by age 2, so diagnosed earlier because of the early manifestation of the disease. And nowadays, more than 50% of cystic fibrosis population is at age 18 or older, and this means something important and indicates something we will talk about later on in this part of the lecture. Now we have to know the pathogenesis of the cystic fibrosis. We have to know that the cause of cystic fibrosis as a hereditary disorder is a defect in a single large gene on chromosome 7 that encodes an epithelial chloride channel called the cystic fibrosis transmembrane conductance regulators, or it's called the CFTR protein. The most common mutation is the F508, although there are approximately more than 1,500 other disease-causing mutation in the cystic fibrosis gene have been identified. So the problem is a gene mutation, where it happened and what is called the CFTR protein. This picture shows the chloride channel, the normal and the abnormal that affected by mutation across the cell membrane. So here is the normal CFTR channel. CFTR, as we say, is the cystic fibrosis transmembrane conductance regulator. This is the normal, allowing the chloride ion to move out of the cell. While in the mutant CFTR channels, because of abnormality in the gene, as we say, that found in the large gene on chromosome 7, there will be blockage of the movement of the chloride ions across the cell membrane, so it will lead to accumulation of thick sticky mucus and build it up outside of the cell. The presence of this thick and sticky mucus will be responsible on the initiation of the pathology that related to the cystic fibrosis, because the problem in the salt and water movement across the cell membrane, as we say, is resulting in the thick secretions that could happen in various organ systems, mostly affecting the lung and exocrine glands. And if you ask about example of exocrine glands, of course you will say pancreas. We say cystic fibrosis is example of malabsorption due to digestive failure. So this picture will illustrate peculiarly the effect of the mutation of the CFTR on the intestinal function. So as you see here, the intestinal epithelial cell, and because of the CFTR mutation, this will lead, as we say, to the abnormality or blockage of the chloride ion to be passed outside of the cell. So this will lead to accumulation of thick mucus outside of the intestinal epithelium and in the lumen of the intestine. So what happens if thick mucus accumulate? It will lead to intestinal dysmotility. It will lead to repeated and or chronic antibiotic exposure that happened from impaired bacterial killing and low intestinal pH that will lead to altered bacterial composition, that's to say overgrowth of E. coli and reduction of bifidobacterium species. So the problem that happened here, accumulation of thick mucus outside of the intestinal epithelium, and the problems happen successively. Now, what are the clinical manifestations of the cystic fibrosis? As we say, cystic fibrosis is multisystemic disease. So it affects the respiratory system, lungs, and the airways, leading to recurrent respiratory exacerbation, and it affecting the GIT, leading to many of abnormalities, and it could affect the liver and the biliary system, leading to gallstone or biliary cirrhosis, and it affects the pancreas as a part of the exocrine gland, and will lead to exocrine pancreatic insufficiency and fat soluble vitamin abnormalities. And of course it affects the skin, because as we say, the problem in the movement of the water and salt across the cell membrane will lead to changes in the movement of the sodium and the chloride outside of the skin, leading to excessively salty sweat, and it affects the bone, leading to osteoporosis, arthritis, hypertrophic pulmonary osteoarthropathy. And it affects, as we say, the exocrine gland of the reproductive system, leading to congenital bilateral absence of the vas deferens, especially in males. So the problem, happened especially in males, leading to infertility. So now we can divide the clinical manifestations, because this is an example of the malabsorption, and our concern and our approach to the cystic fibrosis is from the port of digestive system. So we will divide the clinical manifestations into gastrointestinal manifestations and extra-intestinal, as we do in celiac disease. So if we will talk about the gastrointestinal manifestations, we have to say that they can be varied according to the age of presentation. So what if the manifestations can happen and can be shown immediately after birth? We will talk about the Meconium ileus. Why? Because severe intestinal obstruction resulting in insufficiency of tenacious meconium in the terminal ileum. You know now the pathology: accumulation of mucus. And because this is a neonate, newly delivered, so there will be not just the accumulation of a mucus, but of the meconium that normally should be passed by the GIT of the newly delivered newborn babies. So accumulation of this meconium will lead to intestinal obstruction, especially in the terminal ileum. So it affects about 15% of newborns with cystic fibrosis present at birth. As we say, cystic fibrosis could be present at birth immediately or later on. For the Meconium ileus, it affects about 15% of a newborn presented at birth. So the Meconium ileus is virtually diagnostic of cystic fibrosis. What this statement mean? Meconium ileus is virtually diagnostic of cystic fibrosis. This means the infant should be treated presumptively as having cystic fibrosis until a diagnosis can be proved. When you are dealing with a newborn with Meconium ileus, you have to put in the mind this is a cystic fibrosis until you confirm the diagnosis. This is the way, because the early diagnosis and management will make the difference. No. What if the presentation can happen during infancy and beyond? The problem will affect the exocrine gland, which is the pancreas. So it will lead to pancreatic insufficiency. And pancreatic insufficiency, it means failure of the pancreas to produce sufficient digestive enzymes. You remember, this is an example of digestive failure. So the pancreas failed to produce sufficient digestive enzymes to allow for the breakdown and absorption of which part of the food, of fat and the protein, leading to malabsorption. And this could be total exocrine pancreatic insufficiency, or it could be partial. So if we will talk about the total exocrine pancreatic insufficiency, this is presenting in neonates through infancy, and this account for more than 85% of patients with cystic fibrosis. And this is the problem when we talk about total exocrine pancreatic insufficiency. So it affects babies and will lead to a failure to gain weight despite of good appetite. And the complaint will be the baby can't take the meal. It could be the milk, of course, especially in the we are talking about the first 6 months of life, but there is a failure to thrive or failure to gain weight, and there is abnormality in the stool. It will be frequent, bulky, foul smelling, and oily stools, or what we call it the steatorrhea, because excessive fat present in the stool because of incomplete digestion and absorption. And what it could lead to? It could lead to hypoproteinemia and anemia as a sequences of malabsorption. And of course, this will affect the vitamin, fat-soluble vitamins A, D, E, and K because of the ongoing steatorrhea. What about the partial exocrine pancreatic insufficiency? And the problem here will be mild because the insufficiency is partial, of course. So it can presented at any age, starting from neonatal period and infancy. Not like the total. The total presented at the neonatal period through the infancy. And it affects just 10 to 15% of patients with cystic fibrosis. This is unfortunately. And this will lead to occasional diarrhea, not a frequent steatorrhea as we mentioned in the total. And of course, because it is a partial exocrine insufficiency, will lead to mild growth delay. So that was about the pancreatic insufficiency. And now, as you see here, we put the title of carbohydrate intolerance. Yes, this is 1B. This is maybe one of the manifestations of the cystic fibrosis at the age beyond the neonatal period or immediately after birth, in the neonatal period and beyond, or infancy and beyond. So carbohydrate intolerance, it could present at any age, and it affects about 10 to 25% of patients with cystic fibrosis. And of course, if we talk about the manifestations, so it's characterized by abdominal pain, flatulence, continued diarrhea. And which type of diarrhea and carbohydrate intolerance? Who guess? Yes, osmotic diarrhea with adequate enzyme replacement therapy. What this mean? Continued diarrhea with adequate enzyme replacement therapy. Because the problem is another part of the cystic fibrosis as a digestive failure, not just for the carbohydrate intolerance. Because if it is just carbohydrate intolerance, so the adequate enzyme replacement therapy will solve the problem. Small bowel bacterial overgrowth. This is maybe a manifestation of cystic fibrosis as a gastrointestinal manifestations beyond the neonatal period or immediately after birth. So what about this? Again, this can happen at any age, and this is carry a high risk in persons with the previous intestinal surgeries for whatever the cause. And of course, it will be presented with abdominal pain, flatulence, continued diarrhea with adequate enzyme replacement therapy, just like that happened because of the carbohydrate intolerance. And the predominant pathogen in this case it is Pseudomonas aeruginosa. And the final manifestation, or the last manifestation of the gastrointestinal clinical features of the cystic fibrosis beyond the neonatal period or beyond the immediate period after birth, it is could be presented with severe dehydration, hypochloremic alkalosis, and unexplained pancreatitis or cirrhosis. This what mean? Patients with these manifestations should be considered and should be put in our mind. This could be cystic fibrosis. Again, severe dehydration with hypochloremic alkalosis, not each severe dehydration, and unexplained pancreatitis or cirrhosis. Now we will talk briefly about the extra-intestinal manifestations, because we approach these topics from the part of the malabsorption. Productive cough, wheezing, recurrent pneumonias, progressive obstructive airway disease. So, exercise intolerance, dyspnea, and hemoptysis. As you see here, we talk about the respiratory manifestations, because if you remember from the definition of a chronic sinopulmonary infections or sinopulmonary abnormalities, so the most important extra-intestinal manifestations of the cystic fibrosis is that is related to respiratory system. Productive cough, because of the thick viscid mucus found in the lumen of the bronchioles and bronchi and the airway passages, and this will lead to narrowing of them, so it presented with wheezing. And of course the bold layers of mucus, thick mucus, stagnation in the airways will lead to recurrent pneumonia because of the bacterial overgrowth, and will lead to progressive obstructive airway disease. And these problems with time will lead to exercise intolerance, or what we call it the exertional dyspnea, and it may lead to hemoptysis if it lead to injury or irritation of the airways. And we have to focus on this, because unexplained bronchiectasis, rectal prolapse, nasal polyps, chronic sinusitis should be suspected to be due to cystic fibrosis. I mean, the combination of these manifestations should put in our mind this may be cystic fibrosis. So this picture will summarize the problems, especially in the neonate or the infant and young children, starting from the salt tasting skin, chronic respiratory problems and lung infections, poor growth and weight loss, Meconium ileus and bulky greasy stool. This is related to the GIT. Now what about the diagnosis of the cystic fibrosis? How we can make the diagnosis for it? We will start with the simple one and progress forward for the more complicated or sophisticated investigations. If there is a suspicion this problem is cystic fibrosis, so it's best to do a sweat chloride test, and we will check the concentration of the chloride in the sweat. It should be more than 60 millimole per liter, and this should be regarded significant in the presence of one or more typical clinical features, which are the chronic sinopulmonary disease, pancreatic insufficiency, salt loss syndrome, or an appropriate family history, that means sibling or first cousin who has cystic fibrosis. Chronic sinopulmonary disease, now you know it. Pancreatic insufficiency, also now you know it, how it is presented. If it is total or partial. Steatorrhea, failure to weight gain, and other manifestations. Salt loss syndrome, we mean the severe dehydration with hypochloremic alkalosis. Or as we say, an appropriate family history, this means sibling or first cousin who has cystic fibrosis. The second investigation tool is to do the genotyping study, and of course this is a confirmatory test, not available, but we talk about it now because it put the clear-cut diagnosis for the cystic fibrosis, because it is the only confirmatory test that reveal at least 2 disease-causing mutations. You know how many mutations? More than 1,500. But at least if we have 2 disease-causing mutations, it will diagnose or confirm the diagnosis of cystic fibrosis. What we have also in the investigations, the radiologic studies, very important. And in which case, yes, if the cystic fibrosis presented immediately after birth as Meconium ileus, causing microcolon, so it's very important to take an X-ray, plain abdominal film, or contrast enema to show the microcolon. The other is 72-hour fecal fat evaluation. We talk about the steatorrhea. This means excessive fat present in the stool. So the fecal pancreatic elastase and direct pancreatic function test in case of pancreatic insufficiency. Fecal pancreatic elastase, this will reveal the presence of excessive fat. And direct pancreatic function test, this means the lipase enzyme that will be defective in cystic fibrosis. We can assess it. And intestinal mucosal biopsy. What we can see in intestinal mucosal biopsy as an investigation tool of the cystic fibrosis. We will do disaccharide analysis and hydrogen breath test in cases of lactose intolerance. As we say, the second part of this lecture will be about the lactose intolerance, so I will leave this for that time. And culture of duodenal fluid in small bowel bacterial overgrowth. You remember we talk about the bacterial overgrowth in the small bowel because of the accumulation of thick viscid mucus. And if you remember, we say the Pseudomonas aeruginosa is the most predominant pathogen. So culture of the duodenal fluid could help in the diagnosis, especially if you found the expected or anticipated pathogen. Or even not just Pseudomonas aeruginosa, E. coli also. So this picture shows the microcolon and Meconium ileus here. You remember that we say the microcolon or Meconium ileus and immediately born baby, we should deal with it presumptively as a cystic fibrosis until we can confirm the diagnosis. Now what about the treatment of cystic fibrosis? You remember the problem, and especially if we will approach it from the port of the digestive system and of malabsorption. The problem is we concentrate on is the pancreatic insufficiency. So how we can manage the pancreatic insufficiency? Pancreatic enzyme supplementation should be given. This is combined with a high calorie, protein and fat diet to replace the malabsorbed one. So this is the cornerstone. The pancreatic enzyme supplementation is the cornerstone of the GI tract treatment of the cystic fibrosis. And the pancreatic enzyme taken as a capsule, taken immediately prior to each meal and with the snacks also. And we have to give a daily supplementation of fat-soluble vitamins, and we have to give a daily supplementation of salt to prevent the hyponatremia, especially during hot weather. You remember we talk about the salt losing syndrome of dehydration with hypochloremic and hyponatremic alkalosis, so we have to replace the daily salt to prevent this problem, especially in hot weather. That was about the pancreatic insufficiency. What else? Meconium ileus, because you remember about the early and urgent management of this problem if it is presented immediately after birth, because this is a case of intestinal obstruction, of course. So we will manage the Meconium ileus by dislodgement of obstruction with gastrographin enema, This is maybe fair enough to deal with, or in complicated cases the surgery is the way, and if it is the problem is complicated by atresia, perforation, or valvulus, so the surgery is the mainstay treatment of. What about the carbohydrate intolerance? How we can manage it in cases of cystic fibrosis? We have to reduce lactose intake, and we have to give lactase enzyme intake to as the pancreatic enzyme replacement. So we have to give the lactase, which is the lost enzyme in the cases of carbohydrate intolerance. And we have to reduce the gastric pH in partial villus atrophy. And we have to beware of concurrent celiac disease or giardia infection. This is very important. Why? You remember what happened in celiac disease. There will be a total or a subtotal villus atrophy, and it may cause osmotic diarrhea because of the removal of the disaccharide enzyme, which is the lactase, and will lead to carbohydrate or lactose intolerance. So this happened in cystic fibrosis, this happened in celiac disease, and this can happen in giardia infection because a chronic infection affecting the GIT and affect the villi covering or lining the intestinal epithelium. So we have to put in our mind maybe a concurrent or another diagnosis. How we manage the small bowel bacterial overgrowth? By probiotic therapy. And you remember what is a probiotic therapy? It is a safe bacteria useful in management of the bacterial overgrowth, or give oral antibiotics like metronidazole or trimethoprim sulfamethoxazole. This is efficient, or according to the local culture and sensitivity by the duodenal fluid culture. And to cover all the management of cystic fibrosis, we will talk about the lung disease affected by it. And of course, we have a recurrent infection, sinopulmonary disease. So airway clearance therapy is very important by the mucolytic and by expectorants and by physiotherapy to remove the thick and visible mucus that may block the airways and leading to atelectasis. This is very important, and of course this should be happening concomitantly with aggressive antibiotic use. And in end-stage lung disease, there is no solution, just the lung transplantation. And nowadays they talk about recent clinical trials using a protein rescue therapies to improve the CFTR function. You remember the primary problem of the cystic fibrosis in the transmembrane conductance regulator protein that's affected by the mutation on the chromosome 7. So if we will deal with the primary problem by what's called the protein rescue therapies, it may improve its function and would allow to the chloride ion to move outside the cell and prevent the buildup of the thick and visible mucus, which is the primary problem for all organs affected. But this is just recent clinical trials. And finally, we will talk about the prognosis of the cystic fibrosis. A few decades ago, the cystic fibrosis was fatal early in childhood. But nowadays, the median age and median life expectancy is around 35 years of age. So, what makes the difference? This is due to antibiotic therapy appears to be one of the primary reasons for this rise, because you see here the chronic sinopulmonary diseases of the lung will lead to the bronchiectasis and will lead to recurrent or chronic lung infection, and will lead to airway obstruction and other complications. And in end stage, the treatment is lung transplantation. This means complete respiratory failure. So the antibiotic therapy directed toward this problem and the development in this part of the management appear to be one of the primary reasons for this rise, as we say. So I will take for an example for you. In Canada, because we say it is more common in the white race, in Caucasian, so the disease is common in that population. So today there are more cystic fibrosis adult than cystic fibrosis children. You remember the diagnosis, about 75% of them made up at the first 2 years of age. But because of the improvement in the management of the early diagnosis, improvement in the management and the control of the complications, this will lead to increased life expectancy. So we can see patients with cystic fibrosis at the adult age group. And almost 60% of cystic fibrosis patients are diagnosed within their first year of life. This is in Canada. And for Canadians born today with cystic fibrosis, the estimated median survival age is now 51.8 years of age. Again, this is because of the improvement in the management of the complications of cystic fibrosis and primarily of the lung disease, and due to the aggressive and progress in the antibiotic therapy. So can you see here, this young guy is a 22 American bodybuilder. He complained of cystic fibrosis, but he appeared to be pass all the complications and withstand to survive and become a bodybuilder, although he has the cystic fibrosis, which was a fatal disease in the early childhood few decades ago. Firstly, we will review the outlines of this part. At the beginning, introduction of lactose and lactose enzyme and the lactose metabolism will be discussed. Definitions of lactose intolerance and lactose malabsorption will be taken. Classifications will be done for the lactose intolerance, and the pathophysiology will be shown. Clinical manifestations will be described, and the diagnosis will be approached, and finally the management will be established. But firstly, we have, as we say, to define the lactose. Lactose, it is a disaccharide sugar composed of monomers or monosaccharide, galactose, and glucose. It is the primary carbohydrate found exclusively in mammalian milk. It makes up about 2 to 8% of milk, and it gives the milk its sweetness. It is the sugar found in breast milk and the standard infant formula. That's why when we remove the lactose from the standard formula for the certain circumstances and prescribed for that cause, we hear always the complaint from the parents about the bitter taste of this milk that can be refused by the babies because of the absence of lactose. In addition to milk and dairy products, the lactose can be found in bread and baked goods, processed breakfast cereals, instant mashed potatoes, candies, dressing, and mixing for pancakes and biscuits. Now, what is lactase enzyme? Lactase enzyme, it is a glycoside hydrolase enzyme. It's involved in the hydrolysis, the breakdown of the disaccharide lactose into constituent galactose and the glucose monomers. Lactase is present along the brush border of the enterocyte lining the villi of the small intestine. So the site of action of lactase and of hydrolysis of the lactose, it should be in the small intestine. In humans, the lactase enzyme is encoded by the LCT gene, which is located on long arm of chromosome 2. Lactose intolerance sometimes is called lactase deficiency. This means the deficiency of the enzyme lactase, or sometimes they call it hypolactasia, which is the most common form of all syndromes of carbohydrate malabsorption. Now, this picture will explain the process of the breakdown and metabolism of the polysaccharides. For example, starch glycogen, it is hydrolyzed by the salivary amylase into the disaccharides. It could be lactose, sucrose, or maltose. And in the small intestine, by the presence of glycoside hydrolase enzymes, that could be maltase, the maltose will be hydrolyzed into two glucose molecules, while the sucrose, under the effect of sucrase enzyme, it will give the monosaccharides one glucose and one fructose, while our concern is about the lactose, which is under the effect of lactase enzyme. It will give, as we say, the glucose and galactose. So now we will define the lactose intolerance. From its name, it means intolerance, inability to tolerate lactose. It is a clinical syndrome of one or more of the following: abdominal pain, diarrhea, nausea, flatulence, and or bloating after the ingestion of lactose or lactose containing food substances. So now I think some of you will say, I have these manifestations and symptoms after taking the lactose or lactose containing food. So may I have lactose intolerance? And the answer will be yes, and we will see how. Well, the definition of lactose malabsorption is the physiological problem that manifests as lactose intolerance. So it's the primary problem, and it is attributable to an imbalance between the amount of ingested lactose and the capacity for lactase enzyme to hydrolyze the disaccharide. So the process of incomplete absorption of lactose manifested as clinically as lactose intolerance. Now, the amount of lactose that will cause symptoms, it is vary from individual to individual, and it is depending on the amount of lactose consumed and on the degree of lactase deficiency and the form of food substances in which the lactose is ingested. Lactose intolerance has been recognized for many years as a common problem in many children and most adults throughout the world. So that's why we say, yes, you may have some sort of lactose intolerance. You are not an exception. Now we have to classify the lactose intolerance. And the lactose intolerance will be classified according to its causes into four main types. Firstly, it is the primary lactase deficiency. This is caused by relative or absolute absence of lactase that developed in childhood at various ages, and it is the most common cause of lactase deficiency. The primary lactase deficiency is the most common cause. It is also referred as hereditary lactase deficiency. The second type is the secondary lactase deficiency. This is resulted from a small bowel injury, a transient, we say secondary and maybe a transient, like the example acute gastroenteritis, and we talk about this in the lecture of the acute diarrheal diseases, and especially on the acute gastroenteritis due to rotavirus, or it may be caused by the persistent diarrhea or small bowel overgrowth or other causes of injury to small intestinal mucosa. Like what? Like celiac disease or cystic fibrosis, as we take in the first part of this lecture. Yes, so this can present at any age, but it is more common in infancy. The congenital lactase deficiency here is extremely rare, and as we say, this is congenital, so it is hereditary and it is an autosomal recessive disorder. So the infants with congenital lactase deficiency would not be expected to survive before the 20th century. Why? Because before the 20th century, there is no readily accessible and nutritionally adequate lactose-free human milk. So a substitute was not available at that time, and because this is here a congenital lactase deficiency and no lactase activity at all, so they will not be survived before the development of the lactose-free diet. And finally, the last type is the developmental lactase deficiency, and this is can be seen in the preterm infants who is born before completing 34 weeks of gestation, and this is sometimes called as relative lactase deficiency, and with time the lactase enzyme activity will be approaching to the full activity. Actually, in practice, we have very frequent examples of the developmental lactase deficiency, and we sometimes put the babies on who take the standard formula on a special formula that's lactose free to overpass the period of relative lactase deficiency until it approaches for its full activity. Now, what about the pathophysiology of lactose intolerance? So whatever the reason of the lactase deficiency, primary, secondary, congenital, developmental, symptoms are caused by the insufficient level of lactase in the lining of the duodenum. So this picture will show the process of the pathophysiology of lactose intolerance. Look at here at this part of the picture. Here is the small intestine, and you know the small intestine, it is the part that is responsible about the complete hydrolysis of the lactose. This is that happened in normal circumstances. Under the effect of lactase enzyme that found in the brush borders of the small intestine, it will be hydrolyzed, as we say, into galactose and glucose. But in cases of absence of the lactase enzyme, what will happen? The lactose will pass from the small intestine to the large intestine. And what happened here? Now look at this part of the picture. By the effect of bacteria that found in the colon, the lactose will be undergo the process of fermentation, and this is differ from the hydrolysis. So the result of fermentation of the lactose in the large intestine under the effect of the bacteria found in the large intestine, it will produce copious amount of gases like hydrogen, carbon dioxide, and methane, and other, and this will cause various abdominal symptoms that happen, like the abdominal distension, bloating, diarrhea, and even dehydration. So the hydrogen gas, this can be measured in a breath, and this is the cornerstone in the diagnosis of the lactose intolerance, as we will see, because it will be passed through the bloodstream to the lung and can be exhaled during the expiration. But the unabsorbed sugar and fermentation products, not just to produce the copious amount of gases. It will also raise the osmotic pressure of the colon, and this is causing an increased flow of water into the bowel, like here, delivery of the water. This will cause osmotic and explosive diarrhea, and if it is so frequent and cannot be replaced, of course it will lead to dehydration. Now, what about the epidemiology of the lactose intolerance? Overall, about 65% of people experience some form of lactose intolerance as they age past infancy. That's why some of us will say, yes, we have the symptoms after ingestion of lactose containing food. It is as low as 5% among Northern European and as high as more than 90% of adults in Asia. And this is follow the evolution theory. They say in Asia they are not dependent on the milk, while in the primary feeding of that populations, in Asia, especially East Asia, they have a different and bizarre dietary habits, and nowadays we may be the victim of this abnormal dietary habits conveying the viruses to us in this pandemic of the COVID-19, that may be due to ingestion of bat or bat soup, as they say. We are not sure about this, of course. So we will back to our subject. Because of the partial dependence or on the milk by the people of East Asia, so the lactase enzyme didn't develop in its activity to the level like that happened in Northern European and other societies that depend completely on the milk and dairy products. So it may be more common in the adult in Asia because of that reason. This is follow the evolution theory, as I say. About more than 20% of Hispanic, Asian, and black children less than 5 years have evidence of lactase deficiency and lactose malabsorption, while in the white children typically do not develop the symptoms until after a age of 4 or 5 years. This is about the epidemiology, and this picture will show the geographic distribution of the prevalence of lactose intolerance in recent population. And as we say, here in Asia and in East Asia and in Africa and in Southeast Asia and in the Southern America, they have the highest prevalence. And the Middle East and North Africa, where we live, it is about the second degree of the lactose intolerance, while in Europe and North America it is less than us, and in the Northern Europe, as we say, it is the least. I mean, in Scandinavian people and the Great Britain, of course. Now, what are the clinical manifestations of the lactose intolerance? Lactase activity is genetically programmed to decline beginning after age 2 years. This is a fact. And as we say, the problem is lactose malabsorption. Lactose malabsorption because inactivity of the lactase or absence of lactase deficiency, and it may be manifested clinically as lactose intolerance. So firstly, the lactase activity genetically programmed to decline in all of us beginning after age of 2 years. But the signs and symptoms of the lactose intolerance usually do not become apparent until after the age of 6 to 7 years. That means when the lactase enzyme deficiency reach a level that can be manifested clinically. So the symptoms of the lactose intolerance depend on dietary lactose intake and the rate of decline of lactase activity. So if the rate of decline is rapid, it may be manifested earlier than the age of 6 to 7 years, or it may be later if the rate of decline is late or slow. The symptoms are independent of the cause of lactose malabsorption. So in the manifestations of lactose intolerance, we will not depend on the classification whether it is a primary, secondary, or a congenital or developmental. The important issue here is the quantity of ingested lactose, because the quantity of ingested lactose, it may be not tolerated by the amount of lactase enzyme preserved. So these manifestations, it will be abdominal distension and flatulence, abdominal cramping, diarrhea, and could be watery and explosive as we mentioned before, and urgency with bowel motions. Now, how we approach to diagnose lactose intolerance. The first part of diagnosis, as all of us know, is the history. So our good history is important in focusing to reveal the relationship between the lactose ingestion and the symptoms. And we have to ask about the happening of the symptoms after the ingestion of the lactose or lactose containing food. And the second step of the diagnosis is the lactose-free diet test. What is the lactose-free diet test? This could be helpful in diagnosis and in management also, like a challenge test. What we will do in lactose-free diet test? During a diagnostic lactose-free diet, it is important that all sources of lactose should be eliminated. This is the first part. And this requiring reading of food labels to identify the hidden source of lactose. And the trial of the elimination of the lactose from the diet, it will last for 2 weeks. So trial of strict lactose-free milk with resolution of symptoms, and then reintroduction of dairy foods after 2 weeks. If there is recurrence of symptoms after reintroduction of the lactose containing food, so this is regarded as diagnostic test for the lactose intolerance. And that is what we do in giving the lactose-free formula for 2 weeks and wait for the results. If there is response by the absence of the symptoms of the or manifestations, then recurrence of the symptoms, this is diagnostic to say this is a lactose intolerance. And the test that is we have is the hydrogen breath test. What is this? It is the least invasive and most helpful test to diagnose lactose malabsorption in more subtle cases. So it is not usually routine done, just in vague or subtle cases. It is not confirmatory test, but it is very helpful to diagnose the lactose intolerance. How we can perform this test? This is performed by administration of a standard amount of lactose, which is about 2 grams per kg, up to maximum of 25 grams. That is equivalent to amount of lactose of 16 oz or ounce found in glasses of milk. And this should be given after fasting overnight. The fasting should be not less than 12 hours. This test not usually done on babies and very young children. Why? Because it can cause severe diarrhea and leading to the risk of the dehydration. How we perform this test? As we say, we take the lactose. The amount is about 2 gram per kg up to maximum of 25 gram. That's equivalent to the amount of lactose in 16 ounce glass of milk. And you know now because of the absence of lactase enzyme activity, the lactose will be fermented in the large bowel, given the hydrogen and methane gases, and the hydrogen will be exhaled through the expiration, and we can measure the expired hydrogen gas by this test, by this device. And if this test will be done by the clinical gas chromatograph and or compact solid state detector every 15 minutes over a 2 to 3 hour period. So if the level of the hydrogen gas rises above 20 part per million, this is the unit, over the lowest preceding value within the test period, the patient is typically diagnosed as lactose intolerance or lactase malabsorption. So this is the hydrogen breath test, and after given the standard amount of the lactose and frequent measuring every 15 minutes over 2 to 3 period after giving the lactose, for the exhaled or expired hydrogen by this gas chromatograph, if the result is above the 20 part per million, as we say, about previous reading, this is diagnostic of the lactose intolerance. The other test we can do it, and actually we did it usually, is the stool acidity test. It is a screening test, and it is used for infant and young children. And here we will test the pH of stool, and the stool pH in lactose intolerance will be acidic, less than 5.5, and the sabab of this low pH is because of the carbohydrate malabsorption as the result of formation of the volatile fatty acid. The other test we can do is the fecal reducing substances. This is non-specific and less sensitive than fecal pH. Why? Because the presence of reducing sugar in the stool may be attributed to other causes of the carbohydrate malabsorption, like the lactose, glucose, fructose, and galactose, but not sucrose. So stool acidity is prior and preferred in favor of the fecal reducing substance. Intestinal biopsy. Is it a routine to do intestinal biopsy for a patient with lactose intolerance? The answer is no. So it is maybe needed to uncover an underlying GI mucosal problems that is causing the lactose malabsorption. And the example, celiac disease. You remember in celiac disease there will be a total or partial villus atrophy, and by this way the lactase enzyme will be removed and will cause carbohydrate metabolism abnormality or malabsorption from of lactose intolerance. So if we think of underlying cause like celiac disease, we may do intestinal biopsy. But if the diagnosis is just an isolated lactose intolerance, there is no need for this invasive test, and the hydrogen breath test is enough if we want to diagnose it by this way. Now, what are the management of the lactose intolerance? What we can do for them? Firstly, we have to say that no treatment can improve the body's ability to produce lactase. So when your body is deficient of the lactase, there is no way to improve the production of this enzyme again. And all the process is either to remove the lactase from the food or to enhance the lactase activity by certain methods. We will know. So elimination of milk and other dairy product is not usually necessary. This is now regarded as a fact or a new discovery that making a newer approach to lactose intolerance, including the use of the partially digested products such as yogurt, cheese, or pre-treated milk and the products containing the lactobacillus acidophilus, which is partially digest the lactose into glucose and galactose before consumption. This making the need for taking a free diet of lactose is not necessary when we take a pre-treated milk or partially digested products by the presence of useful bacteria called lactobacillus acidophilus. Lactose-free and lactose-reduced milk and lactose-free whole milk for children less than 2 years. This is still approached, and this is still applicable in the management for the children less than 2 years of age. But beyond infancy, the substitute for cow milk could be based on the rice, soy, or other proteins are readily available and generally free of lactose. So this is a way to overcome the problem of lactose intolerance. One way of the management of lactose intolerance is to take an oral lactase replacement capsule or pre-digested milk or dairy products with lactase. This will often permit a lactose intolerant individual to be able to take some or all milk product freely. So oral lactase replacement capsule taken before the meal act as useful in making the lactose intolerance less evident. And in patients who are decided to be on lactose-free diet, it's very important to supplement the calcium and vitamin D, because the strong relation between the dietary lactose and the calcium absorption. It enhances the calcium absorption, so removal of it from the diet, we have to replacement of the calcium and vitamin D, and this is according to schedule, depend on the age group of baby, starting from since birth up to 18 years of age. Now we talk about lactose-free formula, and we didn't know what we mean by this. A lactose-free formula, it is a milk that is refined to remove the lactose and replace it with different carbohydrate, usually corn syrup or sucrose. And we say it is of a bitter taste because of loss of sweet taste of the lactose. The nutritional quality may be less than the standard formula because of the absence of lactose. And usually tastes better, as we say, because of the technology, not just because of the absence of the lactose, but because of the technology that's required to hydrolyze the protein into more easily digestible units, making it bitter taste or adding a bitterness for the taste in addition to the removal of or absence of lactose. In acute gastroenteritis, that is like the viral gastroenteritis, there is enough lactose digestion and absorption are preserved, so that the low lactose or lactose-free formula have no clinical advantage if compared with the standard lactose containing formula. And so no need for put on lactose-free formula, except in severely malnourished or undernourished children, or warm lactose containing formulas may worsen the diarrhea, and lactose-free formula may be advantageous. So this is a clinical judgment according to the status of your patient. If you will remove the lactose or given lactose-free formula, or contain or go on and given the standard formula in acute gastroenteritis, according to a clinical judgment based on the clinical situation of your patient. And finally, we have to say breast infants should be continued on human milk in all cases. And this is in all circumstances. This is again give the advantages of the breast and the human milk, that is cannot be replaced by any other standard or medical formula. And if there is no absolute contraindication to go on in human milk, so there is no need to cease the breastfeeding in those infants with lactose intolerance. This picture shows the formula of lactose-free milk, and all of these not available in the Iraqi markets. Now we are reaching to the end of our lecture. Please keep protected from the COVID-19 by staying at home and wearing the mask, and of course washing your hands frequently. Wish you good health and thank you for listening. See you in next lecture.